This presentation really focuses on NRG1 fusions, looking at both the landscape and natural history of patients with NRG1 fusion positive cancers. The context here is that neuregulin, also known as NRG1, is a protein that goes to the cell surface where it's cleaved to result in circulating NRG1. NRG1 can bind to HER3, causing HER2-HER3 heterodimerization and activation of physiologic HER2 signaling. NRG1 fusions, so genomic alterations in NRG1, have been described in patients with solid tumors, many different solid tumors, but at rare frequency, less than 1%. And these fusions anchor NRG1 to the cell membrane, causing increased activation of the HER2-HER3 pathway and growth and cellular proliferation. There are many different potential therapeutic approaches that have started to emerge for treating patients with NRG1 fusion positive cancers. And this includes monoclonal antibodies that block neuregulin from binding to HER3, HER2-HER3 bispecific antibodies that block neuregulin binding and further hinder HER2-HER3 dimerization, and tyrosine kinase inhibitors that block HER2 signaling downstream. The most robust clinical data to date is from Zenocutuzumab, which is a HER2-HER3 bispecific antibody. And a recent paper of the phase 2 basket trial demonstrated an overall response rate of 30% in this population with a median duration of response of 11.1 months. The majority of patients had either non-small cell lung cancer or pancreatic cancer. The overall response rate in lung cancer was 29% with a median duration of response of 12.7 months. And in pancreatic cancer, the overall response rate was 42% with a median duration of response of 7.4 months. On the basis of this data, the FDA granted accelerated approval to Zenocutuzumab for patients with advanced non-small cell lung cancer and pancreatic cancer with NRG1 fusions that had progressed on prior systemic therapy. Despite emerging evidence that NRG1 fusions are clinically meaningful biomarkers, the clinical pathologic features of patients with NRG1 positive cancer remain poorly understood. And so our goal really was to describe patients with NRG1 fusion positive solid tumors at our institution, Memorial Sloan Kettering Cancer Center, and also focus on the pathology, genomics, and real-world outcomes in patients with NRG1 positive pancreatic cancer. Prior research has looked specifically at the lung cancer patients, and we have demonstrated that these patients respond poorly to standard chemotherapy and immunotherapy, but it really remains an ongoing question whether that is similarly the case in other diseases. So in terms of the methods, we looked retrospectively at patients at Memorial Sloan Kettering who had diagnostic testing with either DNA or RNA that identified an NRG1 fusion. The raw sequencing data was reviewed to confirm that the fusion was in frame and retained the EGF-like domain, which is necessary for binding of neuregulin to HER3. Clinical pathologic data was manually extracted from the medical record, and NRG1 positive pancreatic cancer cases underwent additional central radiology and pathology review, extraction of treatment data, and real-world progression-free survival. Notably, there are some challenges in detecting NRG1 fusions. There are multiple isoforms that have alternative splicing, several transcription start sites, and tissue-specific expression. There's not one isoform that contains all of the exons to use as a universal reference. And the introns are very large, which preclude coverage on current DNA-based panels. So really, RNA is superior for detecting these NRG1 fusions. In terms of how we detected these at Sloan Kettering, but as I said, both DNA and RNA were used. The majority of patients were detected on RNA, and we have a workflow where if a patient is driver negative by DNA, they get RNA testing. So many patients were identified in that way. In total, 63 fusions or structural variants were identified. 15 were ultimately thought to be of unknown significance, and 48 were felt to be pathogenic. Looking at the demographics, about half of patients were male, about half female. The median age of diagnosis was 61 years old, with a wide range from 9 to 83 years old. The majority were white non-smokers and were diagnosed with stage 4 disease. The most common tumor types that we identified were lung cancer in 60% of our cohort, pancreatic cancer in 21% of our cohort, followed by breast and hepatobiliary in 10 and 6% respectively, with one patient having cellular neurothecoma. Notably, there were several other cases that were observed in patients with other disease histologies, but these were ultimately thought to be of unknown significance when looking more closely at the genomic data. 46% of patients were treated with a HER2 and or HER3 targeted therapy, and the vast majority were treated with a HER2-HER3 bispecific antibody. Looking at the detection, so 34 patients were detected on RNA alone, 11 on DNA alone, and 3 both. And of the 32 co-tested cases, 29 were identified on RNA alone. So this really supports the importance of doing RNA testing to detect these fusions. There were 21 unique fusion partners identified, the most common being ATP1B1 in 40% of cases, followed by CD74 in 40% of cases, followed by ATP1B1 in 10% of cases. And the fusion partners, often, they were typically upstream. EGF, the EGF-like domain in NRG1 was downstream, and the fusion configurations were pretty similar across the board. The patients all had no tumor mutational burden high status, so they were all TMB low, and they were microsatellite stable. No patient with lung cancer had another driver alteration, so these were driver negative aside from the NRG1 fusion. And similarly, all of the pancreatic cancer patients were wild type for KRAS. Looking at the demographics of the pancreatic cancer patients specifically, we identified 10 patients with pancreatic cancer harboring NRG1 fusions, 7 male and 3 female. All of them were white, most were non-smokers and diagnosed with late-stage disease. The pancreatic lesion location was at the head in 40% of cases, at the tail in 10% of cases, in the body in 20%, and overlapping in 40%, so a distribution. And the most common sites of metastasis were liver and lymph node. Patients were treated with chemotherapy in the metastatic setting, most commonly FOLFIRINOX or FOLFIRI, or a gemcitabine-based regimen. Looking more closely at the pathology in these patients, the NRG1 fusion positive pancreatic cancer patients have a distinct histopathology compared to KRAS mutated pancreatic cancer. This includes smallular tubular structures lined by cuboidal cells with minimal intracytoplasmic mucin. There were 6 distinct fusion partners in this group of 10 patients. 5 of the patients had ATP1B1 as their fusion partner, and 5 had unique fusion partners. The median progression-free survival on first-line chemotherapy for advanced disease was 8.3 months. And this is in line with the data from similar populations in larger clinical trials, although the numbers are very small. What we did notice were that some patients had these very prolonged disease courses and what seemed like more indolent disease, but this is still something we're looking into. So in conclusion, NRG1 fusions are a newly described clinically actionable target in solid tumors. The most common tumor types identified were non-small cell lung cancer and pancreatic cancer. The detection of NRG1 fusions remains a challenge, and currently RNA testing is superior to DNA for detecting this alteration. There are many upstream partners. CD74 is the most prevalent in lung cancer, and ATP1B1 is the most prevalent in pancreatic cancer. These are typically otherwise driver negative, and patients with NRG1 fusion positive pancreatic cancer have a unique histology and potentially a unique natural history.